In the tubular transport, the most important tubular transport is the sodium reabsorption. So we have to pay every details of attention to this because three most important syndromes, that is the Bartter syndrome, Gitelman syndrome and Liddle syndrome, comes under the same topic only. So it is highly scoring. So MCQ's probability is very maximum. So first I'll explain the general structure that we have drawn here. So this is the lumen of the nephron. So this is the lumen of the nephron. Then this side from the lumen, the reabsorption is taking place. That side is called as the apical side. So this is our apical side. And the next one, which is towards the blood vessel, it is also called as the basolateral side. Basolateral side. So this will be the same for all the diagrams. Basolateral side. So we have to remember all the transporters involved in this mechanism of sodium reabsorption. So first let's start with our PCT, that is the proximal convoluted tubule. The channel number first one that transports both the sodium and as well as the glucose. So what is this channel? It is nothing but a sodium glucose co-transporters. That is sodium glucose co-transporter, SGLT, and the type here is usually the type 2 is predominant, even though type 1 is present but type 2 is predominant. Now coming to the next channel, which is the sodium hydrogen. Sodium is going in, so basically we are trying to reabsorb the sodium. So sodium is going in and hydrogen is coming out. So what is this channel? This channel is sodium hydrogen exchanger. This channel is very important, that is sodium hydrogen exchanger. Now coming to the third channel, that is the sodium is taken along with the amino acids. So the third channel is sodium amino acids. AA is for amino acids. So the third channel is sodium amino acid, and this is a co-transporter because it is transporting both of them towards the same direction. So it is a co-transporter. Now if the question arises, which channel among this is maximally reabsorbing sodium, because we know that 2/3 of the sodium reabsorption is done in the PCT. Among these three channels, which is maximally involved? Most of you people are writing the answer as SGLT. No, it is not the correct answer. The correct answer for this is the sodium hydrogen exchanger. This is the most important channel which is transporting maximum amount of sodium inside the PCT. So this is the most important channel. This is an MCQ, you have to remember. Second thing is, there is one another hormone which is also stimulating this sodium hydrogen exchanger. That hormone is angiotensin. Angiotensin. It is not aldosterone, it is angiotensin. Angiotensin 2 can directly stimulate this sodium hydrogen exchanger. It is positively influencing the sodium hydrogen exchanger. So it is also involved in sodium reabsorption. Then this is all the channels in the apical side. The most important channel being the sodium hydrogen exchanger. Now coming to the basolateral side, usually most of the channels, these are secondary active transports. So we need some amount of energy from the basolateral side, and the energy is provided usually by a sodium potassium ATPase. That is the classical channel, which is the sodium potassium ATPase channel. This channel we will find it in many segments of the nephron. So this is the common channel which is involved in many segments. Then there is another bicarbonate channel which is going along with the sodium. Now the sodium from the lumen is transported to the cell. From the cell it has to go to the blood. So it is going along with the bicarbonate. So this channel is called a sodium bicarbonate symporter, like co-transporter. It is transporting both of them together. So this is all about the PCT. You have to remember sodium hydrogen exchanger and angiotensin stimulating it. These two are the important points. In some of the segments, we will see that some of the ions are going through this route. What is this transport called as? It is called as paracellular transport. In between the two cells, it is being transported. So it is called as paracellular transport. So this is also important. Now coming to the second segment. We all of us know that descending loop of Henle is permeable only to water. So obviously there is no question of sodium reabsorption there. Now coming to the thick ascending loop of Henle. Even in the thin limb, I told you there is not much of transport. Now coming directly to the thick. From the PCT, we are jumping to the thick ascending limb. This is our thick ascending limb. So this is the center as the lumen, then this is the apical side, this is the basolateral side, and that is the blood vessel side. In this, we have various channels. The first one being the most important one, which is called as NKCC channel. This channel is called as NKCC. What does this NKCC stands for? It stands for sodium potassium 2 chloride channel. Sodium potassium 2 chloride channel. So this channel is also very, very important. This channel we already saw it in the tubulo-glomerular feedback. Yes, very good. Because it is present in the macula densa, which I told you it is present in the TAL or the thick ascending limb. Now coming to the channel number 2, so we will write down the channel number here, that is the NKCC, that is the first channel. Now coming to the channel number 2, it is throwing potassium outside. This channel is called as ROMK, that is renal outer medullary potassium channels, but we don't have to remember the full forms, just remember it is ROMK channel. Now coming to the other channel, there is one chloride transporter which is situated in the basolateral membrane on the TAL. Now chloride which has come in, it is going out through the CKCl channel. So it is going and reaching the blood. So this chloride is going into the blood. Then again for some of the energy, the sodium potassium ATPase is present here also. So the classical channel here comes along to plate. So what is the third channel? The third channel is CKCl, that is a chloride channel which is transporting the chloride in the basolateral site. Then the fourth one, that is not a channel, it is a protein which is attached to this CKCl. That protein is called as Bartin. This protein is called as Bartin. Whenever any of these channels that we discuss is defective, it leads to a syndrome called as Bartter syndrome. The syndrome is nothing but Bartter syndrome. This is our first syndrome we are starting to discuss, the Bartter syndrome. The primary channel affected here is our NKCC, that is the Bartter type 1. And whenever ROMK is affected, it is called as Bartter type 2. And for the chloride channel, it is called as Bartter type 3. And finally, the type 4 version, the Bartin protein is affected. This Bartin protein is affected in the ear also. The ear also has this Bartin protein. And if it is affected, what will happen? The person will have deafness. If the person is having deafness along with a renal disorder and a protein is asked, it is Bartin. And the second thing is it is Bartter type 4. There are 4 variants of the Bartter syndrome and it is type 4. And obviously the NKCC is the one which is most common type. This is the most common type. So we have to understand what are all the symptoms present in Bartter, because in the options you will be getting Bartter syndrome also, then Gitelman and Liddle syndrome also. So all of them will be in the option. So all their individual features and their differentiating features are very, very important. So let's discuss about the Bartter syndrome features. I told you the Bartter syndrome is happening in the thick ascending limb and it is affected channel is NKCC. So first N is affected, that is sodium reabsorption is affected. So what will happen to the levels of sodium? There is decrease in sodium reabsorption. This is one segment we have to discuss very slowly. So make sure that you pay attention to all the details. Then second channel is NK is for potassium. Here the potassium is decreased, so it is forming hypokalemia. So this is also important. Then C is for the chloride. Now chloride is also not reabsorbed. What will happen? It will lead to hypochloremia. Hypochloremia. So these are the features of NKCC. Then what happens is, because of the potential that is created by this ROMK channel, positivity is created. So what will happen is, there are 2 ions which are being reabsorbed for this positivity creation. This side we have become more positive. So magnesium and calcium, they move through in between the cells. What is this route called as? This route is the paracellular route. This route is paracellular route. It is reaching the blood directly. So now if any of the above channels are affected, this potential will not be created. So obviously even the magnesium and the calcium reabsorption is also affected. So how will be the presenting? He will have hypomagnesemia also. Hypomagnesemia. So all these events are happening in the blood. That is hypokalemia is happening in the blood, hypovolemia is happening in the blood, hypochloremia is happening in the blood, then hypomagnesemia is happening in the blood. Then finally, I told you calcium reabsorption is also affected. Ideally, we should write hypocalcemia, but none of the books write that. Why? Because calcium hemostasis, you will read up in endocrinology, there are various hormones involved in this calcium hemostasis. So here, apart from this mechanism also, even if this calcium is not reabsorbed also, the blood calcium can be maintained by other mechanisms. So I cannot write hypocalcemia. Instead, they would have given a term hypercalcinuria. Now, urine is producing more calcium, like calcium is more sent into the urine. It is called as hypercalcinuria. It is going in the urine. The calcium is going in the urine. And know the reason why it is not mentioned for the blood, because blood has various other mechanisms. Even this calcium, if it is not reabsorbed, still the blood calcium levels can be maintained. So that is why we use the term hypercalcinuria. So Bartter syndrome, they will give an extensive sentence in most of the books. The extensive sentence is nothing but all the features of it. They would give a sentence like, this is very important for Bartter, that is hypochloremic metabolic alkalosis with hypercalcinuria and nephrocalcinosis. There is hypercalcinuria with nephrocalcinosis. And another feature is there can be hypomagnesemia with nephrocalcinosis also. Hypomagnesemia. So all these features are important. I have given explanation for all of them, most of them, like hypochloremic, we said, hypercalcinuria, nephrocalcinosis, because now the nephron is sending out more and more of calcium, so it can get calcified and will cause nephrocalcinosis. Hypomagnesemia can happen. But I have mentioned one term, that is metabolic alkalosis. How does this metabolic alkalosis happen? Just wait for the next two segments. There we'll find the answer. Then we'll come back to this metabolic alkalosis. But right now, trust me, it is the metabolic alkalosis that is happening in this person. So coming to the next segment, that is the DCT. We are done with our thick ascending limb. Now coming to the next segment, that is the distal convolutal tubule. What is the ion channel present here for sodium reabsorption? That first we have to see. The ion channel present here is NCC. What is NCC? It is reabsorbing sodium along with chloride. Here there is no potassium. That's why K is not there. So sodium is reabsorbed along with chloride. Then again we have one more channel which is also called as the potassium is sent out through the same channel. That is nothing but our ROMK. But instead of magnesium and calcium going in the paracellular route, here calcium has one more additional symporter, like one more additional transporter. That is the calcium transporter is present, which brings in the calcium inside the cell through this mechanism. And basolateral side also, we have to remember two channels. One channel, our classical sodium potassium ATPase, that is no confusion. And another channel we have to remember, which is very, very specific for this DCT. That channel's name is sodium calcium exchanger. Sodium calcium exchanger. Here the calcium which has come here, that is going to the blood with the help of this exchanger. So the sodium exchanger happens here. And in the paracellular route, one ion goes in, which is called as the magnesium ion. The magnesium ion goes to the paracellular route from here also. So one notable difference that we have seen with the previous segment is the calcium ions which is going through this and the calcium sodium exchanger. That will give us a clue to differentiate it between the different syndromes. So coming to the syndrome, if the NCC is affected, what is the syndrome? The syndrome is called as Gitelman syndrome. The syndrome is called as Gitelman syndrome. So in Gitelman, just remember the mnemonic, gentleman go to NCC. Just remember it as gentleman go to NCC. Usually people who goes to NCC are behave like gentlemen. That's why this is the mnemonic. So gentleman, NCC is affected. So what is the features? What is the feature that will happen? So the first feature, there is no sodium reabsorption. That is a common feature. So there is a decrease in sodium reabsorption. So that is happening, which is understandable. And whenever there is sodium reabsorption is decreased, it will produce hypovolemia in the blood. The blood hypovolemia will happen. Then what happens to the potassium? Now this channel is blocked, so potassium will be exiting. So it will cause hypokalemia. Then what will happen for the levels of calcium? There is a tricky note here. What happens is the sodium levels, whenever it comes down inside sodium is less because now this channel is not functioning. The NCC channel is not functioning. So what will happen? So whenever this channel is not functional, what can happen is this channel, the basolateral channel, which is the sodium calcium exchanger, that will be hyperactivated. Why? Because it will try to pull in more and more of sodium inside the cellular. Cellular is now deficient of calcium. The cellular is very much deficient of sodium. Sorry, the cellular is very much deficient of sodium. So this hyperactivated channel will try to bring in more and more sodium inside the cell. But whenever it is bringing more and more sodium inside the cell, what will happen? More and more calcium has to be reabsorbed and sent into the blood. So can I write hypercalcemia? I cannot write that because calcium hemostasis depends on many factors. Instead, we can write hypocalcinuria. So this hypocalcinuria. In the previous disorder where the Bartter, we saw hypercalcinuria. But the major difference between a Bartter and a Gitelman is hypocalcinuria. This is the major difference between them. Now, again, one more magnesium that also cannot be transported if this positivity is not created by the potassium. So, what will happen? This magnesium will cause hypomagnesemia. So, this hypokalemic feature is not mostly seen because here the ROMK channel is not much affected, but this hypocalcemia and hypomagnesemia is seen. Hypocalcinuria and hypomagnesemia is seen. This hypocalcinuria is the differentiating feature between a Bartter and a Gitelman. Now coming to the next segment, that is the collecting tubule. In the collecting tubule, we have two different types of cells. One is the principal cells, another one is the intercalated cells. We have two different types of cells. One is the principal, another one is the intercalated cells. Here in this segment, we have a specific channel for sodium reabsorption, which is called as ENaC channel. So this ENaC channel is the one which is bringing in the sodium. It is bringing only the sodium in. What is this ENaC channel? This ENaC channel is nothing but the epithelial sodium channel. This is an epithelial sodium channel. So this will bring in the sodium. And what will happen? The basolateral, again the sodium potassium ATPase will be operated. Whenever the sodium is being reabsorbed, what will happen is it will throw out more of potassium. So first it will start throwing out potassium out. Second, whenever the sodium reabsorption becomes more and more and more, what will happen is first potassium will be thrown out, then H plus also is thrown out. H plus is also thrown out. So this we have to remember. So this will make the differentiating features. And here one more hormone acts on this receptor, that is the aldosterone. The aldosterone acts on this receptor and it increases the activity of ENaC channels. Not only ENaC channels, it also increases the activity of this ROMK channel, that is a potassium channel, and it also increases the activity of sodium potassium ATPase. That's why aldosterone has a very good ability to increase sodium reabsorption and increase the ECF volume also and correct the hypovolemia. That is the function of aldosterone. We all of us know. But whenever this aldosterone level is increased too much, what will happen? All the activity of all the channels is increased and the person will have increased volume. In case of hyperaldosteronism, this we will be discussing again in endocrinology also. This hyperaldosteronism, whenever it is also called as Conn syndrome. Whenever there is too much of aldosteronism, what will happen? The increase in activity of ENaC channels is happening. Not only ENaC as well as ROMK as well as the sodium potassium ATPase. There is another syndrome which is a gain of mutation. Till now, Bartter and Gitelman, we were seeing there is loss of function. But here the third syndrome, that is the Liddle syndrome, is having a gain of mutation. There is a gain of mutation of this ENaC channel. So what it will mimic? It will mimic something similar to that of the hyperaldosteronism. What is the only difference? In hyperaldosteronism, two more channels are being activated. That is the increase in ROMK as well as the sodium potassium ATPase. Whereas in Liddle syndrome, only the ENaC activity is enhanced a lot. So what will be the features of Liddle syndrome? First thing is sodium reabsorption is more. There is an increase in sodium reabsorption. So this will cause hyperolemia. Out of this three, only hyperolemia is present here. Then it can also cause hypertension in the patient. Then another things what will happen whenever sodium is reabsorbed, I told you potassium is thrown out. So it will form hypokalemia. Hypokalemia. But whenever the action is more and more, first initially potassium will be thrown out, but later on, which will be thrown out? Later on, the H plus will be thrown out. Whenever H plus is thrown out of the body, what will happen? There will be metabolic alkalosis because acid is thrown out. So there will be metabolic alkalosis. So these are the classical features of an Liddle syndrome. Now we have to go back and fill our gap of metabolic alkalosis in case of the Bartter syndrome. So let's try to go back and find out what is happening there. Here also there is metabolic alkalosis. How this is happening? What happens in case of a Bartter syndrome is the sodium reabsorption in thick ascending limb is not happening. So there will be this sodium. Now what will happen? The sodium is not reabsorbed. They will put more load on the next segments, and finally they will put more load on the collecting tubule and the ENaC channels. Now more sodium is available for the ENaC channels. So the activity of ENaC channel is increased. So whenever ENaC channel activity is increased, what will happen? First, it will send out the potassium. Next, it is going to send out the hydrogen. Whenever hydrogen is sent out, it will cause metabolic alkalosis. So indirectly, this sodium load on the ENaC is there, which is causing this metabolic alkalosis. I hope it's clear. Now we will discuss and summarize all three syndromes. All these three syndromes are very important. So coming to the summary, we are going to summarize all the features. Coming to the Bartter syndrome, in which area it is affected? It is affected in the thick ascending limb. Coming to the Gitelman, it is affected in the DCT. Coming to Liddle, the gain of function happens in the collecting tubule. In the diagrams also we have mentioned that and coming to the channels, in Bartter it is NKCC, Gentleman go to NCC, then Liddle it is the gain of function of ENaC. These both are laws of function. Laws of function. This is also a laws of function. Only gain is the ENaC channels. So this is given in the diagrammatic representation also. The NKCC channels are in the thick ascending limb. And one more additional feature of this NKCC channel is the loop diuretics. The loop diuretics can block this NKCC. So all the features of NKCC block or the Bartter can be seen in loop diuretics also if it is abused and overused. So that is example for a loop diuretic is furosemide. Now coming to the second segment, that is the DCT. DCT NCC is there. If it is affected, it causes Gitelman syndrome. And there is another group of diuretics which can influence this NCC, that is the thiazide group, thiazide diuretics, which acts on the NCC channel. Then coming to the Liddle syndrome, where the ENaC channels are increased, but it can be inhibited with one group of drug, that is the amiodarone. Now let's summarize the features so that it's easy for our MCQs. So these are the feature differences. So there is hypovolemia in the first two, whereas hypervolemia happens only in case of an ENaC gain, that is a Liddle syndrome. Then hypercalcinuria in case of a Bartter, hypocalcinuria in case of a Gitelman. This is the differentiating features between Bartter and Gitelman. And metabolic acidosis happens in two places. Metabolic alkalosis happens in two places. One is the Bartter, another one is the Liddle syndrome. Then there is hypomagnesemia, hypochloremia, hypopotassium, that is hypokalemia in case of a Bartter, whereas hypomagnesemia happens in case of Gitelman also. The differentiating features are this hypervolemia and hypocalcinuria. So this is the points to remember for all these three syndromes.